Franzen, interventional pulmonologist, and he will talk about extended indications and possibilities done by endoscopic interventions.
Thank you, Walter, for this introduction, ladies and gentlemen. After my morning talk about the bronchoscopic diagnosis of lung cancer, I switched my topic to bronchoscopic treatment of lung cancer. So first, I want to talk about status quo. No, I want to talk about the status quo of the current indications for bronchoscopic treatment. By the way, this is Rick Parfitt. He has died last month, not because of lung cancer, as all rock musicians. He died because of an infection of the shoulder surgery. So the current indications for bronchoscopic treatment of lung cancer are mainly against the bronchoscopical visible tumor, also of central lung cancer. The principles are, I think, older than me, and I'm proud to have learned these techniques from Lutz Freitag, which is the current head of the interventional department here. It is highly recommended to do this by rigid bronchoscopy, and the technique is as follows. You take the rigid bronchoscope, then you have the laser to make a devitalization of the tumor tissue. Then you're going to core out by twist and advancing the scope, and at least there is a hemostasis, again with laser or with argon plasma. Normally we try to follow these guidelines here of central airway obstruction. The first question is the patient an emergency patient? That means, is the patient dyspnoic? If yes, then an immediate intervention is indicated. Then it depends on the fact if there is submucosal stenosis or an exophytic tumor. In case of submucosal stenosis, you're going to dilatate or a stent implantation. And in case of exophytic tumor, you can core it out by rigid bronchoscopic. You can applicate the laser or APC. In case of a stable situation, then you have time for tumor board and whatever. And if the patient is curable, sure, surgery should be offered or radiation therapy. And if not, there are treatment options with bronchoscopy. So first, I want to talk about the exophytic tumor approach. I talked about laser, argon plasma, and cryotherapy. Each of these techniques has different cons and pros. You see the laser has at least almost all cons of speed of this obstruction and hemostasis. However, laser does not have any anti-tumoral activity, and laser is costly, and it's not without any harm and risk. APC is somehow in the middle, and cryotherapy is interesting because there is some anti-tumoral action by inducing apoptosis to the tumor tissue. Here we use the YAG laser for debulking and for hemostasis. The complication rate is quite low. Depending on the energy you applicate to the tumor, we are working from 10 to 40 watt. And depending on the localization of the tumor, you have different success rates of debulking. That means the more central the tumor is, the higher is the success rate. I have one example here. This is a young lady. She's 24 years old. She was highly dyspnoic. Came to the emergency department. At emergency bronchoscopy, we saw this is a very good vascularized tumor. And then we took her to the interventional lung center and applied the techniques as I told you before. That means we made a rigid bronchoscopy. We began with a laser, so you can look for minutes here, because it's a very low energy laser, just 10 watts, but what you see is that the tumor is going pale and pale and pale. That means he's devitalized. Thereafter, the tumor looks like this here, and then you can make a passage into the depth of the bronchi, and you see here there is a normal bronchial mucosa. Then we took the electrocautery here. This is just a wire on the current, on the electric current. Here you see the wire. Then you make like a cowboy with a lasso over this tumor. You give some current on it. You see the current. Now we can extract the tumor, and then at the end there's just the rest of tissue, the tissue bases which can be extracted by the rigid forceps. And then at the end of the story there's just the bleeding control with the argon plasma. This is an argon plasma applicator here. Now you see a little bit fire. It's very important that these patients are ventilated with low oxygen, maximum 40%. Otherwise you have an explosion. So this is the final result, and the patient was happy to not have a cancer. It was a benign tumor. So what can we do in case of submucosal stenosis for dilatation and for stenting? For dilatation, sure, the rigid bronchoscope is the dilatator. And then what can you do to hold the bronchus open? There are a bunch of stents which can be implanted. These stents should be covered in case of malignancy by nitinol and by coverage of silicone. A stent sounds very nice, however, a stent should be the last treatment option because stents do have very much complications. First is the stent fracture. It is very hard to extract a stent who is broken, and you can grab out on the mucosa, which is very bleedy. A stent can granulate, so there are different attempts to overcome this problem by giving some medications on the surface of the stents. However, at the moment there's no good result on these investigations. The biggest problem is the mucus obliteration. We give our patients 4 to 6 times per day natural saline to inhale, and we think this is the best option to keep the mucus fluid and to expectorate the mucus. And the fourth complication is a dislocation. If the external power is decreasing over time, then the stent can dislocate it or can be cuffed up, which can be a very critical situation if the stent is in the vocal cords. Here this was a 36-year-old lady with a very rare carcinoma. It was a spear adenocarcinoma. She had metastasis all over. However, she was highly symptomatic. You can imagine this. This was the bronchoscopic view of her distal trachea, and we could treat her with an epsilon stent, which is here the guide wire, then the stent here, and you see here her airways are reopened again, so she was happy to breathe thereafter. However, she died 1 month later because of tumor progression, but she did not have any symptoms of dyspnea in the end of her days. So what is the extending indications for bronchoscopic treatment of lung cancer? First, there's a photodynamic therapy, a very interesting treatment option. We know this from dermatology, from different skin cancer. you give the patient a photosensitizer. Then this photosensitizer is accumulating in the tumor tissue. Then you're going to radiate the tumor with a laser, with a light, and then the tumor is producing free radicals, and these free radicals do have a very local cellular toxicity, which can then be assessed by bronchoscopy. This was one of these patients with a squamous cell carcinoma who did refuse systemic therapy. He had different mucosal metastasis of his cancer, and then after injection of the photophrene, here this was the autofluorescence bronchoscopy, then thereafter this was the illumination with a special kind of laser, and one day later the tumor had disappeared. He had quite many of these tumors, so this intervention was taking more than 2 hours. Another interesting or possibility is the treatment of peripheral tumors by bronchoscopy. However, that means, like I said in the morning, that means to overcome challenges of navigation. We have these two possibilities of the radial EBUS or of the endobronchial navigation bronchoscopy. Then you have further possibilities to advance the bronchoscope or the forceps to make biopsies and to implant fiducial markers to help radiosurgical interventions, or maybe to give other treatment options here. Maybe localized chemotherapy would be a possibility. However, all of these techniques is not standard of care. Different centers are making some investigation on it. Personally, I'm not convinced about the future of these techniques, since we do have better possibilities with surgery and SBRT. So the take-home message is we have a good status quo which should be followed for further, and then there's Tomorrowland, there's a lot to do, that's why we are here, and I thank you for your attention.